Hi, this is Dr. Tom Rogers coming to you with a weekly podcast of the Common Sense MD. Today's kind of special because I have two guests, as you can see. Dr. Dan O'Roark and Nolan Hensley. He's a PA. As you know, I love PAs. My son Andy's a PA. He's really my hero. But in any event, both you guys are my heroes because you do a cash cardiology practice. I mean, it's so easy for me, a family doctor, to do what I do, cash only. I've been doing it for 17 years. And with what's happened to medicine since I've practiced medicine for 37 years is just unbelievable change in the way corporate medicine, big pharma, government control. We can't get into a lot of that, but everybody knows what's happened in the last few years with, especially the last 3 years with controversial subjects and pricing, and there's no transparency really in medicine anymore. So I was really fortunate when I went cash that deductibles went high at the same time. It's actually much cheaper to see me than it is a regular doctor who will file your insurance. And it has allowed me to become a better doctor, to spend a lot more time with my patients, and I enjoy my practice much more. I'm 68 years old. I'm not going to retire. You know, I'm just at a good spot. And so you guys are the same way. And to be a cardiologist, to have that kind of practice and to go cash only, let me tell you, number one, it's gutsy and it's the right thing to do. And since you went cash, I've had an endocrinologist contact me, went cash, a rheumatologist went cash, and it's just a wonderful thing. So tell me, start with you, Dr. O'Roark. Since you've been doing this, you like your practice better? Tell me how it's changed.
It's been phenomenal. Our professional satisfaction is through the roof. And like you said, we can spend time with the patients and we can render better care. We've had to teach ourselves the benefits of nutritional therapy, diet, and that really is a cornerstone of cardiovascular health, but we never had the time in our old practice to even delve into those things. So it has been going very well for us, but like I said, our professional satisfaction, for me, it's been as high as it's been in 25 years. And as you know, when the third parties are removed from the equation, not only can you practice more pure medicine, but it also lowers your overhead, and those savings can be passed on to the patient.
Mm-hmm. Very transparent.
Yeah.
And it's interesting because, especially cardiology, here's a couple things with cardiologists. We have some great cardiologists in this area.
Sure do. Mm-hmm.
But access is really tough. If you want to get somebody in, say somebody comes in my office, they've got an Apple Watch on, they say, that's all, watch says I'm an AFib. You are an AFib. We've got to work this thing up.
Right.
And, okay, well, I'm going to send you a group. It's going to be 3 months before you get in. That patient does not want that. They want to get in, and when I call your office, you see them that day or the next day. They're very grateful for that, as you would be, because you don't want to screw around with your heart. So that's one thing I like about you guys. There's many things, but access is just huge. Plus, a lot of people don't know. Like I said, there's no transparency. They don't know what kind of bill they're going to get down the line from what they just did.
Right.
One thing that is very interesting for me in dealing with cardiologists, too, I have many friends who are cardiologists, but a lot of times there's so many patients, and they tend to do things cookbook. And here's a couple examples I give you that are very interesting. We run, in my practice over the years, we've run a Boston heart panel, which comes from Harvard, and now we run a Cleveland heart panel, which comes from a Cleveland clinic. Two pretty outstanding companies, wouldn't you think? Like the best in the world. Anyway, one of the first times I ran a Boston heart panel on a patient that just happened to be there, because it checks everything. I mean, detailed stuff I need to know for hormonal analysis and inflammatory markers, vitamins, genetics. I mean, it's just a wonderful test. And so I had a patient that got the test, and I went over the stuff with him, and he had heart disease. He'd had a stent. And I go, are you going to see your cardiologist this year? You should see him once a year to follow up on your stent. He says, yeah, I'll see him next week. So I said, well, just take this Boston heart panel into your cardiologist. He won't have to repeat any of your blood work.
Right.
There's plenty of stuff and more. So he does that. And he comes to see me a month or two later for something else. And I said, how'd it go with your cardiologist? He goes, I'm not going back to him. I go, why not? What happened? And he goes, well, I showed him your Boston heart panel, and he took one look at it and threw it in the trash and said, this is BS. And that I just started laughing my head off because I knew what happened. Yeah. And in the meantime, I ran it by the chief of cardiology around here. Everybody would know who it would be. It was an amazing cardiologist. And he laughed too. And I said, I got my ideas, but why do you think they did that? And he agreed with me. He goes, number one, they didn't know how to interpret the test.
Right.
It's very embarrassing when you're a cardiologist, you don't know what, an LP little a is or an ApoB. Number two, he wanted to run his own for some odd reason. I don't know if it's reimbursement, whatever, but that to me was very telling.
Right.
And I just laughed my head off because he lost a patient, and it didn't. I wasn't looking at myself to look good, but it kind of made me look like I knew more than cardiologists did about some of this stuff. So is that typical?
Yeah, a lot of modern medicine, not just cardiology, is algorithm driven. It's become guideline driven. But again, if you look at the level of evidence in most of these guidelines, it's what they call level C, and level C is expert consensus. Well, how's that any different than my expert opinion, right? Mm-hmm. And so obviously no one would be against properly conducted trials for evidence-based, but the human body is so complex. We're only going to have a small amount of evidence to guide what we do. And so the rest of it really does have to be somewhat empiric, common sense, what works, long-term observation, that type of thing. But that's what we're faced with. And then, of course, the guidelines, they're called guidelines, but then they become gospel, and then you don't want to deviate from them. But not everything that's recommended there is beneficial or even, safe.
Yeah, and it's funny because sometimes they get out of their lane a little bit, like with hormones.
Right.
Many times a patient's in there and they're on a hormone cream, and the cardiologist goes, get away from that hormone. It causes blood clots or strokes. There couldn't be anything further from the truth.
Yeah.
That they don't know anything about hormones. It's not going to cause a blood clot. Right. So they have to kind of stay in their lane. Yeah. The other thing the controversies I've had with them is a patient that's been put on a statin that, in my opinion, didn't need a statin. They come to my office and their total cholesterol is 80. Right. No wonder they have low T. Testosterone comes from cholesterol. Right. So a lot of times they want to drive that down so far, and they put everybody on a statin, which can have a lot of side effects. And I'll ask you, Nolan, when you use a statin, do you think about it, or you just knee-jerk because you're a cardiologist? Do you just knee-jerk putting them on a statin?
Well, previously in former practices, the knee-jerk reaction was, okay, this patient's coming in, maybe their total cholesterol is a little bit high. Well, guidelines say this. I need to put them on a statin. In our practice today, that is not the case. Like I said, we've going and doing the model that we have. It opens the door so much to the medical freedom and being able to treat each patient individually, not just taking that guideline or that cookbook and saying, oh, here's what everybody tells us that we should be doing. You can actually tailor that to that person. I'm much more in favor if someone comes to me with an elevated cholesterol. I would much rather them, through diet, exercise, lifestyle changes, for them to get that cholesterol down versus me giving them a medication that I know has side effects. Mm-hmm. So that's the approach that I take.
And how many patients does it take to save one life for use of a statin? 1,000?
A lot.
A lot. Yeah. I mean, the benefit ratio is really not what they think. Yeah. But it is true in cardiology. What we're looking for is prevention. We want to prevent that heart attack. And I think, that's why I like your philosophy. You know about nutrition. I mean, you have to be. You have to be better than the average cardiologist. You just have to be, or nobody's going to come to you. And you have time to do that now that you don't have to search for codes and spend all your time on an EMR system that's onerous. And
Well, in our practice model, we do have that extra time. Previously, the patients are stacked up. You come in that day, and whatever they've put on your schedule, that's what you have to see. So you cannot take the time to talk about those dietary and lifestyle changes. You may be able to tell the patient, "Oh, you need to lose weight." That's all you have time for. You can't go into what is the recommended diet that you should be following. What is your ideal body weight? How much should you be exercising? We never had time for that previously, but in this model, and that's what patients can see. Once they've come and visited with us, they recognize that we do spend much more time with them. We go much more in depth with them about their cardiac care. Not only that, but their overall health as well.
Yeah, you have the time and expertise to do that. That's funny because most doctors will, on the way out, "Oh, yeah, lose some weight." Then as the doctor's going out of the room, the patient goes, how can I lose this weight? I'm not having any luck. And the doctor on the way out goes, "It's simple. More exercise, eat less." That doesn't work. Right. It's so complex, and doing a lot of work with obesity, it's just very complex. And fortunately, now we have some great tools. If you watch my podcast on medications we can use, because it is a metabolic disease, obesity is. But I'm sure you agree. But anyway, so I'm not going to rant and rave too much more about the medical system. I could certainly do it. But anyway, let's talk about anything new going on in cardiology that you guys are doing. I love it because you run the tests. You want to make sure somebody doesn't have heart disease. So you run the treadmills in your office, and you do the echoes, and you do everything short of cardiac catheterization, I guess. And if you think they need that, you send them. But anything new on the horizon that you're doing, or that you think people ought to think about?
Right now, Tom, we're just doing the basics. There's always new things that are being proposed and that type of thing. But again, the evidence base for those things is not strong. And, just going back to the basics, going back to the old paths, as they say, is the way to do things. But Nolan and I had to retrain ourselves. 5 years ago, if you'd have talked to us, we would have known nothing about inflammation, known nothing about dietary management, would have known nothing about how to promote a patient's body to burn fat instead of glycogen. We would have known none of that, and we're still learning. We and like you said earlier about the testing. When I became familiar with Cleveland Heart Panel, I had to educate myself on some of those things because it just wasn't part of our paradigm. And so we're just doing the basics. But again, we want to focus, like Nolan said, on the foundational. What you eat is foundational to life, and that's the starting point, and it is a therapy. And so we view diet as a therapy, and it's foundational for cardiovascular disease. I saw an essay today where it was predicted in the essay, and it was a very good essay. By 2050, it's estimated that there'll be a doubling of the number of type 2 diabetics. There was a stat in there that I was not aware of. 94% of all diabetics are type 2 these days. When you and I were in our training, if we had a type 2 in our clinics, we had a unicorn in our clinics, right? So obviously there's something environmental. Obviously we think it's largely the diet. So there's other factors, of course, too. But it's these kind of things that we've had a paradigm shift in our thinking. We still do the traditional therapies, but because unfortunately a lot of patients, the horse is already out of the barn. Doesn't mean we don't start. Because it's never too late. But as far as in the outpatient world, not a lot new that we're doing. We're hoping over time that there'll be some lessening of government restrictions, and then we hopefully can offer some cash-based advanced cardiovascular care. Very briefly, just doing a pro forma in my head, we could do a cardiac catheterization at a far lower cost than any hospital system could.
For sure. For sure. It's amazing how the hospital systems have just, especially in this area, it's really unbelievable in my mind. I'm not going to preach about this, but it's unbelievable what's happened to our hospital system in this area. It's downright shameful, in my opinion. If my dad, who practiced general surgery here for 40 years could see what was happening now and walk into these. He turned over in his grave. He couldn't believe it. But in any event, we won't focus on that. What about, tell me some cool stuff that you're doing that has been found to be approved now by the FDA, use of colchicine.
We've been using it for, even in our old practice, we were using it. I came across some data 3 or 4 years ago where they were doing studies on secondary prevention, people who've had stents, who've had myocardial infarction, people who've had bypass surgery, and the number needed to treat was fairly robust, very simple, very safe. Colchicine is very well tolerated, and now that the patents are starting to run off for the so-called Colchris, it's getting cheaper and cheaper. I take it myself. I can get a 90-day supply now for under $50, and it's going to continue to get cheaper. But that gets to the other paradigm, is that again, there's a lot of controversy over, is it all inflammation? Is it inflammation plus cholesterol? Is it more cholesterol? People can debate those things, but inflammation is now has a seat at the table. It is undeniable that inflammation of the vasculature promotes atherosclerosis.
So do you think it's an adjunct to maybe a low-dose statin in some people, or in place of a statin?
Yes. We offer, the data is not as robust. Like I said, the most robust data is for the people for secondary prevention. But let's say we had a patient who had a coronary calcium score of 400. They've never had a clinical event. And non-invasive testing shows no high-risk findings. Obviously, that patient is interested in trying to prevent adverse cardiac events down the road. And we do talk about low-dose statins. We talk about colchicine. But again, lifestyle is a huge, that is our primary recommendation, because as you know, a lot of what we eat, especially in the processed food department, is highly inflammatory.
Yeah, very quickly too. You know,
yeah.
in your bloodstream. But so speaking of coronary calcium scorings, which I order a lot of, tell me that, you know, of course I know you like them. When should you get I get a CT calcium scoring on most of my patients over 40 years old. Women 45, 50 maybe. But when do you need a CT angiogram? A lot of people are talking about that now, how much more accurate that is. Of course, that's going to involve a dye.
Right.
But give me your general feeling about who should get a CT calcium versus.
Nolan can speak to this as well, but I think that we're more selective with that because it is a higher cost, and many of our patients either have high deductibles or they're cash payers. But we generally, if we have someone who has known coronary disease and they have stable symptoms, no high risk findings, sometimes we will do a CTA to rule out heretofore unknown high-risk anatomy. You want to make sure there's no left main disease or 3-vessel disease. We've done some of that. And there are people where you have a young lady comes in, she has some risk factors, has some atypical chest pain, had a negative workup, still has the discomfort. You're not terribly convinced. Those middle-aged people with lower amounts of cardiovascular risk, they're good candidates for the CTA. But generally, to answer your question, it's largely symptoms-driven, and then we put that into the entire context. I don't know if Nolan has a different idea.
The way that I utilize the CT coronary angiogram is mostly it's from patient to patient. Looking at risks versus going straight to a heart catheterization versus a CT coronary angiogram, have to take that into account. Is my patient higher risk by sending them straight to a heart cath where they're going to get larger amounts of dye? You are going to get dye during the CT scan as well, but not as much as you would during the catheterization. And then looking at what does the patient want out of their health? So some patients decide they want to come in and I really don't want to undergo surgeries. I don't want stents. And like Dr. O'Roark was alluding to earlier, we want to rule out and make sure you don't have a high-risk blockage. So in that case, sending them for that CT coronary angiogram, making sure they don't have bad left main disease, multi-vessel disease that would ultimately benefit the most from surgery or stenting. And we want to rule that, take that off the table first, and that way we know what we're offering them as far as medications, again, lifestyle modifications, all of the outpatient options for treatment. we can know that we're giving them the best option there for what they have going on with their bodies.
I agree. I think the baseline preventative is your lifestyle. But what about, Nolan, I'm going to ask you, what about taking an 81 milligram aspirin, which I've been doing since I was 40? It gets controversial because when I recommend it to most of my patients, they say, well, I heard that was bad or not useful. What do you think?
I usually educate almost everyone that comes in the office, no matter what they're there to see me for. We usually end up talking about aspirin in some aspect. Aspirin for cardiovascular health is a wonderful medication. Aspirin kind of got a bad rap in the past few years just because it seemed like everyone was taking aspirin, and maybe there was an increase in GI bleeds. But I think that goes back to lack of education on the behalf of the providers. Maybe they were telling their patients, "Oh, take a baby aspirin," and in their minds, the patient's minds, that didn't correspond with the 81 milligrams. A lot of people, even now, that come and see us, they say, "Oh yeah, I take an aspirin from time to time just to help with my heart." Mm-hmm. And okay, well, what's the dosage? Well, I don't really know. Well, go home and look and call me and tell me. Yeah. Well, I've got the 325 milligram dose. So you take people that are taking 325 milligrams of aspirin every day, and maybe on top of that, they're also taking their ibuprofen or their Aleve to combat their joint.
Ulcer, aren't they?
They're going to get an ulcer in their stomach. So educating patients that a baby aspirin 81 milligrams a day is a good medicinal help to the body, preventing cardiovascular disease as well as other health benefits.
Yeah, like decreased colon cancer, probably pancreatic, esophageal, maybe up to a 40% decline in it. But yeah, you're right. You have to talk to the patient. If they're 90 years old and stumbling all over the place, they hit their head and they're on any aspirin, they may bleed. Those patients shouldn't be on it. Certain other people may not want to be on it, but that's why it's individual medicine.
It is. It's not cookbook. Medicine was not invented to be what we have today in the large scheme of things. It's patient. I think it should be patient driven. As I said earlier, when the patients come in, I want to sit and take the time and understand what are you wanting out of your health. Are you wanting to avoid surgeries if possible? Are you wanting to avoid all medications if possible? Okay, let's start there. Then we'll figure out, we'll tailor a pathway to keep you as healthy as we can and hopefully keep you from having any large events.
In my opinion, medicine is a shared decision process.
It is.
As doctors, we're here to give you our best opinion, advice, but you want to work with the patient. It's our ultimate decision whether they want to take something or undergo a procedure. And I don't blame a lot of them for not wanting to. I had an 85-year-old lady yesterday who was told she needed a bisphosphonate for her osteoporosis. I looked at her stand. She did have some risks, of course, but I said, "Do you want to take this? Here's the side effects." "No." I said, "Fine.
Right.
You don't have to take it." When the other doctor is really going to force her to take it. It's weird because a lot of doctors, if you don't do what they say, they'll kick you out of their practice.
Right.
I don't understand that.
Along those lines, Tom, I have a niece who's a PhD pharmacologist, toxicologist, and we were chatting a few years back, and she mentioned to me that only about 20% of the medicines we prescribe, we actually know how they work. And that's really not a criticism because the human body is so complex, and in medical research they're called confounders. Those are various things that could interfere. Yeah. You can't control for all of them, Yeah. And then you also get the healthy user effects, where you get what's called selection bias, where if you have a sicker control group, well, it's always going to make the intervention group look better. So you have all those different factors. So you just have to use good judgment. We're certainly into scientific medicine, but we have to realize that we have great limitations of the evidence base, and we don't want certain groups to gain control over what the evidence base says.
So you're telling me if you have a big dog doctor who says, "Trust the science, I am the science," it may not be true, right?
It may not be true, right.
I think you know what I'm talking about.
Yes.
But which I can't say it. But all right, here's another thing I want to ask you. This has been awesome. What about a question I get a lot, because I recommend a lot of omega-3s. And recently there's a controversy. can omega-3s cause atrial fibrillation? Because that's in the news right now, and I have a lot of people ask me.
I have not looked at it in great detail. I've skimmed over some of the papers, but again, they're not very robust. And again, you have to control for the other factors. They're saying, well, this patient has atrial fibrillation, took omega-3s, but the patient's 80 pounds overweight, has type 2 diabetes, has undertreated sleep apnea,
Triglycerides high,
uncontrolled hypertension. Well, it's really hard to just blame an omega-3 in that context, right? So those are the things that have to be known when you look at this data. And it is true, it's a controversial statement, but I think it's true, is that the establishment, they are not interested in lifestyle, supplements, dietary management.
there's no money in it.
There's no money in it, right?
That's a shame,
That's
too,
exactly
isn't it?
right.
Isn't that a shame?
It is a shame.
That's what I like about you guys, Dan and Nolan, is that you have common sense. I mean, your expertise, you're scientists, but you use common sense and you actually talk to the patient, and it's shared decision making.
Yeah.
And that's what I like about your practice. I love the fact that you have a cash, transparent practice, and it's very affordable, and it's available, especially with hearts. You don't want to wait on your heart. If you're having heart disease, I mean, I've seen people sent home because they weren't having, the EKG looked normal, they had a heart attack and died the next day.
Yeah.
It's tragic a lot of times.
Right.
So need to take prompt action, and you certainly do. We love sending you patients, and our patients just rave about your practice.
We appreciate that.
Not only
Certainly
the
appreciate it.
expertise, but how kind you are. And us as human beings, kindness to me is the number one thing.
Yes.
I would take a kind person over a PhD that thought they knew everything.
Right.
I think you'll do better.
For sure.
There's a lot of psychosocial aspects of health that
Right.
nobody even ever mentions. I know my dad told me, he says, the most important words that you'll ever speak to a patient as far as advice, and I go, no, he goes, reassurance.
Yeah.
You're going to be okay. A lot of times that really goes a long way.
Yeah.
We've got all our medical expertise, and AI is going to probably take over at some point. That's another podcast we'll do about AI, because it'll be helpful, but it also could be hurtful because, you take the human element out of it and kindness. But anyway, I love your practice. You're doing the right thing, and certainly I appreciate it, what you're doing for the community and for my practice and helping me out, because when somebody has heart disease, I want to get them seen. I want to get them reassured that they're going to be okay.
If I could just comment on that too, one of the problems with the insurance model, it is legitimate to do low-cost, safe testing for reassurance purposes, but as you know, that's not reimbursed. Mm-hmm. And so patients that really want to know, we've had patients, very bad family history, mom, dad, uncles all had carotid endarterectomy. Well, they just want to know what their carotids look like. Well,
and their insurance won't pay for it.
They won't pay
I
for
agree.
those tests.
They need to go to an affordable place like
Right,
you.
right.
In my opinion, really, people should be able to order a test they want and actually pay for it, and for reassurance in themselves, because a patient knows about their own body. And that's why, as doctors, if we listen to our patients, they're going to tell us.
Yeah.
And
we know too that even in cardiovascular medicine, many of the patients that have true perceived heart symptoms, it turns out to be something else. Mm-hmm. So they need that reassurance, but also in differentiation from our prior practice model, it also keeps the doors open for the people who need us this week as opposed to 2 months from now.
That's exactly right. Well, I appreciate you guys so much. A lot of medicine now, and again, when I start ranting about our hospitals around here and all, we have wonderful doctors around here, just incredible doctors. It's not their fault, believe me. It's the system, and it's not just here. It's almost everywhere that you see this, all this medical advancement, but degrading of our life expectancies. I mean,
we're going backwards.
When have we gone backwards other than the last 2 or 3 years in our life expectancy? Right. And here in a country like the United States, with all this technology, all the medicine, the money we spend on medicine, we're like 33 in developed worlds with mortality.
Right.
I mean, it's really shameful.
Right.
It's greed. It's too many rules. It's hampering of your practice. But anyway, I'm enjoying seeing what you guys are doing. It's almost new, old-fashioned type medicine, which I think is the best way to go.
Right.
Anyway, thank you so much.
Thank you for having us again,
And
Tom. We
thank you
appreciate
for-
it.
We thank you for having us up. If anybody doesn't know who we are, Trinity Heart and Vascular Group, we have offices in Greenville and Johnson City, Tennessee. Dr. Daniel O'Roark, he manages the Johnson City office, and I manage mostly in the Greenville office. We do stress testing, echocardiograms, carotid ultrasounds, abdominal aortic ultrasounds, so, and a whole host of other things.
And you know what to do with it.
Right.
And you're going to tell the patient, you know.
Yeah.
So that's what I like. That kind of thing you're doing, just amazing. So I'm sure we'll do more podcasts. This is
Thank
our
you.
second or third one. We'll
Second,
definitely
yep.
keep up. And if I have a question, I always call these guys, you know, hey, what should I do with this patient? And it's always a friendly, I think I need to see this patient, or here's an easy way to handle this.
Right.
So I appreciate that so much. Anyway, this is Dr. Tom Rogers, the Common Sense MD. Thank you so much. We'll see you next week.